now come back to the usual and the classic endoscopic ultrasound, but very interesting topic really, which is linear EUS examination of the normal liver anatomy and its clinical implications. What encourages me to talk about these subjects that over the last 7 or 8 years and during staging or sampling of different intra-abdominal malignancies like pancreatic malignancy, like GI malignancy, esophageal, gastric, duodenal, and even lung malignancy. And during examination of the liver as a routine of EUS examination, I frequently found a small hepatic focal lesion not seen by previous CT or MRI imaging, even few days after EUS examination. And these focal lesions are finally proved to be liver metastases. These lesions are too small, very small, to be seen by normal imaging as CT or MRI. Like that patient with pancreatic head mass, finally proved to be duct adenocarcinoma. And here we can find very nicely a small, it is about 1.2 by 1.5 centimeter focal lesion in the left lobe of the liver in segment 2. And here application of elastography is very beneficial because it nicely recognizes that this small focal lesion is hard in consistency, mainly blue, and there is marked discrepancy between the elasticity of this region and the elasticity of nearby normal tissue. So it is mostly a malignant mass, and the value of endoscopic ultrasound that immediately you can do FNA at the same time and at the same examination, and we can do it very simply and very safely by FNA or FNB, but I think FNA is enough in malignant lesion. It is mandatory in normal liver tissue and chronic pancreatitis and so on, but FNA here is enough to diagnose that this small lesion missed by CT or MRI prove that it is finally a malignant lesion, liver metastasis. And of course, the management of this patient differed completely from operable or resectable pancreatic head mass to inoperable and palliative chemotherapy. So this lesion is an occult hepatic focal lesion. It is seen very nicely by endoscopic ultrasound while missed by CT and MRI. And these patients are so frequent. Every 1 week or every 2 weeks, we can find another patients every 1 or 2 weeks. So these patients are not uncommon. This is another patient with a very well-defined hepatic focal lesion, not seen by CT or MRI. It is about 1 centimeter by 1 centimeter. And at the same session, we can do FNA and finally prove to be liver metastasis. And this patient was referred for palliative chemotherapy. So we saved the patient unnecessary major operation like Whipple's operation, distal pancreatectomy, subtotal gastrectomy, with, of course, high morbidity and mortality even in best centers. This is an example of a third patient with malignant obstructive jaundice, pancreatic head mass, and biliary duct dilatation. And after application of a stent, the bilirubin improved, but the fever and the rigors persisted with leukocytosis. By endoscopic ultrasound examination, we find this small focal lesion in segment 4 of the liver, with an areas of breakdown suggesting liver abscess, a small cholangitic liver abscess, and USFNA revealed the presence of pus cells, polymorphin nuclear leukocytes. So we knew the cause of fever and pruritus, and after proper antibiotic therapy, the patient improved. So what I'd like to say, that examination of the liver during staging of different intra-abdominal masses, whether pancreatic, lung, esophageal, gastric, is mandatory because we can find hepatic focal lesions missed by CT or MRI, which may be liver metastasis or cholangitic abscesses. So it is highly recommended to examine all liver segments thoroughly during any EUS examination, especially for staging or sampling of intra-abdominal malignancy. So my agenda today will divide into two parts. The first one is how to do linear EUS examination and how to examine the normal liver anatomy. And the second one will be the clinical implications of detecting hepatic focal lesions of the liver. I will try to do it as simple as possible. Examination of liver segments by endoscopic ultrasound can be done from the stomach or from the duodenum. From the stomach, we can visualize the left lobe of the liver with its segments 1. Segment 1 is the caudate lobe, segment 2, segment 3, and segment 4A and 4B. And also can visualize part of segments 7 and 8. While examination from the duodenum, we can scan the right lobe of the liver segments 5, 6, which cannot be visualized from the stomach, and segments 7 and 8. Here our landmark is putting the probe of the echo endoscope or the tip of the echo endoscope at the cardium. With gentle clockwise and anti-clockwise rotation, we can search for our landmark, which may be the abdominal aorta. If I find it, then I can do counterclockwise 90 degree to find our landmark to start liver examination, which is the IVC, inferior vena cava. This is the inferior vena cava, and this is the intrahepatic portion of the inferior vena cava, and this is the left portal vein, and this is the right hepatic vein. Why it is the right hepatic vein? Because the widest diameter of the right hepatic vein is its insertion inside the inferior vena cava, with gradual sloping or gradual tapering as it goes deeply inside the liver parenchyma. So this is the IVC, and this is the right hepatic vein. The widest diameter is at the inferior vena cava, and there is gradual sloping as we go inside the liver, and this is the portal vein. Here we can identify nicely, here we can identify nicely 3 segments of the liver. Segment 1 between the echo endoscope and the inferior vena cava, which is the caudate lobe, and this is segment 8, and this is part of segment 7. So at the level of the right hepatic vein and the inferior vena cava, we can see the caudate lobe, segment 1, segment 8, 7, 1, 8, 7. Okay, it is very nicely seen. And then I will do gradual counterclockwise rotation. So this is segment 1, 8, 7. With counterclockwise rotation, yes, I will do now counterclockwise rotation. Yes, now I can see very nicely the middle hepatic vein. The middle hepatic vein opposite to the right hepatic vein. The middle hepatic vein is a long vein, and its diameter is homogeneous all over its course, from the inferior vena cava to going deeply inside the liver. So it has the same diameter. And another landmark is at that level of the middle hepatic vein, I can see very nice fibrous ligaments, which is the ligamentum venosum, communicating the inferior vena cava to the left portal vein. This is the obliterated umbilical vein. This is the ligamentum venosum. So in that view, I can see the middle hepatic vein, homogeneous diameter all over its course, and the very nicely seen ligamentum venosum, communicating the inferior vena cava with the left portal vein. Here I can see also three segments. Segment one is the same, which is the caudate lobe. This segment is between the ligamentum venosum and the middle hepatic vein, which is segment 4A. And this segment is segment 8. So this is 1, 4A, and 8. Now I will keep counterclockwise rotation, further counterclockwise rotation, to visualize the third vein, which is the left hepatic vein. This is very nicely seen left hepatic vein, separating segment 2 from segment 3. Segment 2 from segment 3. Here, as Professor Marco Giovannini tell us that segment 2 is very nice for rendezvous technique, is very nice for antegrade application of stent. But segment 3 is more suitable for for hepaticogastrostomy. Now this is segment 2 and segment 3. So to read, first we localize the inferior vena cava at the cardia. This is the inferior vena cava, and this is the intrahepatic portion of the inferior vena cava again, and this is the right hepatic vein with the widest diameter at its insertion to the inferior vena cava. Here we can find three segments. To repeat again: 1, 8, and part of segment 7. Counterclockwise rotation, I can locate the second vein, which is the middle hepatic vein, homogeneous diameter all over. And at this level, I can find the ligamentum venosum. And this is segment 1, which is the caudate lobe, segment 4A between the ligamentum venosum and the middle hepatic vein, and segment 8 below the middle hepatic vein. And this is the umbilical portion of the left portal vein. And deep to this left portal vein, deep to the left portal vein is segment 4B. And this is the last view which you saw in the previous video, which is the left hepatic vein separating segment 2 from segment 3. Now we will have one step further, which is completing the examination of the liver from the stomach, is, as Professor Marco Giovannini said, I push the echo endoscope inside the patient approximately at 50 to 55 centimeter from the dental arch. So it is a more deeper location. It is suitable for hepaticogastrostomy biliary drainage. So I will push here the echo endoscope. Yes, I will push the echo endoscope gradually inside the patient. And I should localize what is known as fish eye appearance. Yes, I will start now to push the echo endoscope inside the patient, and here is very nicely seen fish eye appearance, which is the left portal vein. Left portal vein located at 50 to 55 centimeter from the dental arch. At the left portal vein, which is the fish eye appearance, I can see two ligaments. Ligament going to the right of the screen, which is the previously mentioned ligamentum venosum, and another ligament going to the left side of the screen from the left portal vein, which is the ligamentum teres. Here, ligamentum teres and the left portal vein separate segment 3 from segment 4B. Segment 3 from segment 4B. Here, segment 3 is suitable for hepaticogastrostomy biliary drainage. So this is a very nice picture of the fish eye appearance, the umbilical portion of the left portal vein. This is the ligamentum venosum going to the inferior vena cava, and this is the ligamentum teres going to the anterior inferior angle of the liver. Ligamentum teres and the fish eye, the left portal vein, separates segment 3 from segment 4B. Now we examine the liver from the stomach, and you can see beautifully segment 1, caudate lobe, 2, 3, 4 and part of segment 7 and part of segment 8, but we didn't see segment 5 or segment 6, which may harbor many metastases. These two segments and also segments 7 and 8 can seen from the bulb of the duodenum. We introduce the echo endoscope inside the bulb of the duodenum, and then we push it very gently and very slowly against the superior duodenal angle located just after the bulb of the duodenum. Very gentle pushing against the superior duodenal angle, but very gentle, very slow in order not to induce perforation. The echo endoscope will take the G-shaped pattern, and here I can visualize clearly the portal vein. And thanks to Dr. Ahmed El-Miligi, who helped me to prepare this video. This is the portal vein here. And then I will start to do counterclockwise rotation. Counterclockwise rotation to look at the rest of the liver. The portal vein will divide into its two branches. The right branch is going up, yes, and the left branch is going down. So this is the left portal vein, and this is the right portal vein. With more and more counterclockwise rotation, I can trace the right portal vein. I can trace the right portal vein into its two branches, right anterior and right posterior. Yes, very nicely seen. Right anterior and right posterior. This is the right anterior and this is the right posterior branch. The part of the liver in between the echo endoscope and the right anterior branch is segment 5, and this is segment 8, and this is segment 6 between the echo endoscope and the right posterior, and segment 7. So this is 5, 8, 6, and 7. And these segments of the right lobe can be seen from the bulb of the duodenum. Segment 6 can be more clearly seen if we do the opposite. While in the duodenum, in the upper second part of the duodenum, I can do maximum clockwise rotation till I see the right kidney, not the left kidney. Till I see the right kidney, the part of the liver as the level of the right kidney is segment 6 of the liver. So from examination of the stomach and duodenum, but be very careful in the duodenum in order not to induce perforation, we can see nearly all segments of the liver. The most difficult one to be seen is, of course, segment 5 and 6. So let us talk about a little about the clinical implication, just a few slides. EUS is very important in detecting small liver metastases not seen by multi-detector CT and dynamic MRI. Although these imaging techniques are the most widely available and acceptable non-invasive modality for detection of liver metastasis, but they frequently miss lesions smaller than 1 centimeter. The discovery of a previously undetected liver metastasis by EUS could have a major impact on staging of malignancy and changing the management plan. A prospective single-center study by Singh et al. In 2009 showed that EUS and USFNA had a diagnostic accuracy of 98%, very high diagnostic accuracy, while multi-detector CT has a diagnostic accuracy of only 92%, with a higher number of metastatic liver lesions detected by endoscopic ultrasound, 40 cases versus 19 cases. Another prospective single-center study conducted on 98 patients with malignant esophagus and cardiac lesions concluded that EUS had 80% diagnostic accuracy in detection of the occult hepatic lesions that were not evident on prior non-invasive imaging. And a third article by Babel et al. Also reported that a large percentage of lesions, about 70%, especially those smaller than 1 centimeter in diameter, were missed by conventional CT imaging and MRI. This encourages us to start our prospective study on that item, I think 5 to 6 years ago, and now we reached more than 700 patients with malignant lesions in the pancreas, lung, esophagus, stomach, peritoneum, and the results are very promising, and the results will be available in a very short time. So to summarize, the sensitivity of CT and MRI varies according to the size of the lesion. For lesions more than 2 centimeters, the accuracy of both techniques are very convenient, more than 90%. But in hepatic lesions between 1 and 2 centimeters, the range of sensitivity is 71 to 87 for CT and 65 to 78 for dynamic MRI. But for lesions smaller than 1 centimeter, the sensitivity became very low. It is about ranging from 38 to 55% for CT and 26 to 47% for dynamic MRI. So my take-home messages are: it is highly recommended to do thorough and meticulous examination of the liver segments, which is mandatory, especially in staging of pancreatic, GI, and lung malignant lesion to detect occult liver metastatic lesions not seen by CT or MRI. Of course, this will lead to changing the management of the patient. Liver segments are examined from the stomach and the duodenum, and in every anatomical site, try to identify the landmarks of each anatomical regions. And thanks for your attention.
Thank you, Dr. Hussein. Very nice and innovative lecture. And now, Dr. Hakan, please prepare your lecture to be.
Professor Hussein, excuse me, Ahmed, I want to ask Professor Hussein many questions.
Discussion, but
we have still 5 minutes for discussion, Dr. Ahmed Murad.
Yes.
And then we will have a short break during which Dr. Hakan will try his presentations.
It's my pleasure to ask you, Professor Hussein, as regards the problem of seeding. Is there any probability of seeding from the liver if we have FNA or FNB from the liver? Secondly, as regards the technical issue, we have to, I think, we have to increase the depth, so we have to adjust our machine on 5 megahertz rather than 7.5 megahertz. And last question, that this may open the interventional EUS guided therapy, for example, radio frequency or alcohol injection, as long as we can manage the position and the sites of the lesions. Thank you, Professor Hussein.
Regarding the first question, there is no articles whatsoever talking about seeding during EUS FNA. I think during EUS FNA, the seeding is much lower than percutaneous, because during EUS examination, you pass just from the wall of the stomach to the liver, and you pass through the visceral and parietal peritoneum. But during percutaneous sampling, you pass through the skin, subcutaneous tissues, muscles, and also the peritoneum. So the seeding during endoscopic ultrasound is much less, the incidence is much less than percutaneous sampling. The second question is, yes. No, the frequency is the same. I am always working on 7.5 megahertz, and it is very nice. I just decrease the depth. It is very clear. It is very clear. No need to increase the frequency. No need to increase the frequency. If you increase the frequency, you will miss the far lesions of the liver. But I am always working in 7.5 megahertz. Regarding the third question, yes, there are many articles about EUS guided radio frequency ablation of single 1 or 2 hepatic focal lesions instead of percutaneous. Yes, and the needles used are two types of needles, that of Tai Wong, which is EUSRA, and that of Habib, but I think Tai Wong, but the cases is not, it is applied to the liver, but the cases is not too much to reach a decisive conclusion. But it is used, radiofrequency ablation of the liver is used by Tai Wong needle. Yes. Alcohol injection, I have no experience, but if you apply it from percutaneous route, you can apply it from by EUS route. But all the articles or the literature about percutaneous managing of hepatic focal lesion, all are demonstrating or reporting that radiofrequency ablation is much more effective than alcohol injection. Alcohol injection may be useful in very small lesions less than 1 centimeter, but if it is more than 1 centimeter, the effectiveness of radiofrequency ablation is much more than that of alcohol injection. And what is applied to percutaneous route, I think it will apply to the EUS route.
Thank you.
I have a question, Dr. Hussein, please.
Yes.
Shall we sample every hepatic focal lesion we find? Sometimes in evaluation of pancreatic head masses, we find a hyperechoic hepatic focal lesion, and we are suspecting that is hemangioma. But in such a situation, shall we sample such lesion, or depend on another imaging, such as PET scan or?
Yes, a very good question. If you find a lesion suspicious of metastasis, you should sample it. But if the lesion is characteristic of, for example, hemangioma, or characteristic of hepatic focal lesion, hepatic focal fat depletion, focal fat depletion are usually have sharp angles or geographic margin, so no need to sample focal fat depletion, no need to sample classic hemangioma. So if the lesion is highly impressive of benign lesion based on EUS picture, then don't sample it. But if in any suspicious lesion bears the possibility of being a malignant lesion, it should be sampled. I found many hepatic focal lesions during EUS examination of pancreatic and GI malignancy, but if it is a simple cyst, I didn't sample it. If it is looks like a hemangioma, I didn't sample it. If it is focal fat depletion, this depends on the experience of the endosonographer. I am working in the field of sonography for about 30 years now, about 10 years before my EUS experience, 30 years of sonography. So I have a nice experience with different hepatic focal lesions. So I sample only the suspicious lesions, not all lesions, of course.
Thank you very much, sir.
So
Then I think,
if you can illustrate to us, because we tried to do this exam of the liver, and I really loved your lecture, how to do the tail exam and not to miss any part. This was very informative, and it is a good quality exam, and I think we should push for that. But sometimes these occult lesions are so hard to detect. Like, can you give us some clues about how you see them? Because sometimes you would miss them. And we send patients for Whipple, and they found that they have liver lesions. And a lot of times they're almost isoechoic. What's your experience with this almost isoechoic liver mets?
yes, very, very, very nice questions. We started, as you told you, our experience, our prospective study 5 to 6 years ago, and EUS missed about 1% of liver metastasis. And the problem in EUS is that it can't see segments 5 and 6 properly. That is my problem. It is very, 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 very easy to visualize all segments 1, 2, 3, 4, 7, 8, but segment 5 and 6 and sometimes segment 7 are very difficult to be visualized. But I think even isoechoic lesions can be seen if it is located in segment 2, 3, 1, or 4. You can pick it. It has a border. It has a margin. The fallacies of endoscopic ultrasound in visualizing hepatic focal lesions are usually due to location and not the size or texture of this lesion. If it is located in segments 5 or 6, it is very difficult to visualize, or difficult. If you carefully and thoroughly persisted to visualize it, you may visualize, but really it is very difficult segment. But of course, you can miss isoechoic lesion. Of course, you can miss isoechoic lesion as you mentioned, but I think the big fallacy and the big failure, or the failure of EUS to visualize the focal lesion, not the size of the lesion, because EUS can detect even 3 millimeter lesions, but the fallacy is due to location in segments 5 and 6. And we missed many lesions by EUS about 2 centimeter. It is a large lesion. Why? Because it is located in segment 5 and 6. So I agree with you that isoechoic lesions are difficult to be visualized, but the most difficulties is the site of the mass in segments 5 and 6, and not the size, of the mass or the texture of the mass. I hope that I can give you a clear answer.
That's perfect.